want to get started with this discussion. I started doing this talk a few years ago as our response. Is that better? Okay. I started doing this talk about 3 years ago as a discussion of how we started utilizing FDG PET for infections. I'll go through how we began that process and why we needed to get rid of indium-111, white blood cells, gallium, things of imaging agents of that sort. We'll go through this a little bit. At my facility, Lewis Gale Medical Center in Virginia, we have a very simple mission statement. Our mission statement says, and each employee signs this mission statement as they are hired on, as we are committed to the care and improvement of human life. That is a very simple, straightforward statement. In the last few years, we've focused much energy and resources into molecular imaging, such as PET-CT, cardiac PET-CT with ammonia. That is something that we like to do, and we'll discuss that here in a little bit. SPECT-CT, molecular therapies such as Xofigo and Zevalin and things along that line. Research, and then infection imaging. At my facility, we did operate 4 gamma cameras and 1 PET-CT. I've taken 1 gamma camera out of service because its image quality was subpar. So my goal here is to show how molecular imaging can help guide and directly affect treatment for patients with suspected infections with PET-CT. And I'd like to talk a little bit about hardware and to cancer, using case studies to show some examples in real clinical instances of how it's occurred in our facility. So why worry about infection? With the current annual mortality rate of around 35% worldwide, infection remains a significant concern, and the diagnosis and localization of infectious foci is an important health issue. It's often a quality of life issue. An established infection imaging modality, nuclear medicine, plays a vital healthcare role in the diagnosis and subsequent effective treatment of this condition. So, who am I talking about? Most of the infection imaging we're looking to comes from basically causes of a symptom: pain, swelling, fever, weight loss, general unease feeling, abnormal lab work, CBC, SED rate, something along those lines, or abnormal and inconclusive anatomical imaging, such as CT, MRI, things like that. Most of inpatients in this setting cannot have traditional imaging due to renal insufficiency, diabetic issues, or etc. A lot of these patients are very, very ill. I am talking about the septic patients. I am talking about patients on ventilators and units, in our intensive care units. These are the people that I'm referring to. So we often ask our clinicians to pose a question for us to answer, a referral. For example, can you identify site of infection? Do they have osteomyelitis? This can come in any way. We find that our hospital specialists, physicians, don't really know which imaging test to order. They allow the nuclear medicine physician to make these choices. And this is often a two-way conversation. So with multiple agents for the same indication, it is impossible for our infectious disease, our hospitalists, or really any subspecialty to keep up. They don't know when to order indium or indium sulfur colloid or indium MDP or gallium or PET. So we ask that you allow the expert to do that. We see this as a growing problem, as you've heard Giorgio talk, where you can have 15 different tracers in PET-CT. It's very difficult for a medical oncologist to keep up with what's going on in this rapidly evolving field. So I just wanted to show this. You can find this article in Molecular Imaging Today, and you can write this down. This is an article a physician and I put together, and we'll go through some of these case studies here shortly. So the mechanism of action. FDG uptake visualized in patients with infection represents accumulation of activated leukocytes responding to the infectious agent. Activated white cells demonstrate increased expressed glucose transporters resulting in elevated uptake. This is similar to cancer. In contrast to oncologic PET-CT, the increased glucoreceptor availability is proposed to occur by the effect of various cytokines and growth factors. So protocol, I know we're dose heavy on this. I do expect us to go down, but patient is fasting except for water. You do have to be careful when you're in this patient population. A lot of these patients their IV drugs are hanging with D5 or D50 or some sort of glucose material. A lot of these patients are on TPN. A lot of these patients they're trying to get calories into them. These are very ill, sick patients. So you have to be very careful in your screening process. We do check their blood sugar. Same with make sure patients warm setting IVs or using IVs. They're hydrated. We inject 15 millicuries, which I do think in this patient population, we will be going to 10 very shortly. We allow them to rest quietly. Frequently, we inject them in their unit bed or on the floor of the hospital, and then we do image everyone, top to head. So you can say we do these patients in one bed position, and we'll get into this a little bit more. So I like to show case examples of real life patients. So this is a 71-year-old male came into our emergency room, brought by his daughter for persistent fever. He just wasn't feeling well, and she was having a hard time getting him to eat, and he was losing weight. So he had not been checking his temperature, but not feeling well for weeks. So in the ER, his temperature was 101. So in the admit note, the doc felt he was dehydrated and needed some observation. So he was put into the hospital. So patient did not feel any better by day 3. So where infectious disease doctors came and saw him, his temperature had stayed at 101 for those 3 days. His lab works looked like an infection. They started with CTs. They were all normal. They didn't find any masses, any fluid accumulations. So he was sent to molecular imaging for a consult. So under review of this patient, no mass, no fluid, no history of cancer, no HIV or immune compromised status. So the nuclear medicine physician thought the best test would be a PET CT. So here's his PET CT. As you're looking at this axial slice, you can see very obviously this increased level of activity in the gluteal cleft. That was obviously found very suspicious. We went back and reviewed his CTs, and I went back and talked to the radiologist that read his CT scans, the physician, and he didn't think anything about it. You can still see there's a thickening here, but as you're looking at CT scans or doing SPECT CT or PET CT, you'll see that the fold and things like that it's easy to blow by and miss things. CT is very good for seeing things, but every patient is different. It can be very difficult. It's why when you go back, that jumps out at you. That is very obvious. You go back to the CT, and it's really easy to miss that. That can be just anything, any generalized thickening. So it's easy to biopsy. A simple punch biopsy showed the type of infection he had and allowed you to pick a specific antibiotic. This is very similar to chemotherapy. Now you're able to pick based on what you need the antibiotic that will basically allow you to direct treatment. So show you another example. This is an 84-year-old man reported to our ER, thought to be septic. He had blood in his urine, pain, recent falls, and complex medical history. So when we're looking at this, he had an injury in his left shoulder, moved to the hospital. They went ahead and just put him on broad-spectrum antibiotics. And that's dangerous. In the U.S., we have a problem with MRSA. You have patients that basically are immune to many antibiotics. And if you keep treating with all kinds of antibiotics, you can make things worse. So they ordered an infection PET scan, and I apologize. These pictures are hospital-based systems, so they're very plain. But you see this, activity in the sternal joint. You don't think a whole lot about that. It's really easy. Most of the experienced PET CT readers, this used to be a false positive. I would say that they would rarely call that now. But when you look at the whole picture, so activity around the left sternoclavicular joint as well as reactive lymph node. But also the PET showed, that's the great thing about PET, these little lymph nodes, nodules in the lungs, basically that is what keeps you up. Now, the way that we do this is this allows you to biopsy the hottest nodule. So that's the most likely piece of evidence you're going to get the best information. And that's with cancer, infection, or really anything. So septic emboli in the lungs showed disease progression. This led to multiple biopsies due to his history of prostate cancer and the diagnosis of a staph infection. Sorry. The PET helped to find the safest place to biopsy, which left to the best options for treatment. So I'll show you another case study. A recent example of how pet infection helps our physicians with their discharge planning. A 71-year-old female with a very complex medical history, including CVA, a stroke, right-sided weakness, altered minimum status, and a fever. So, the one thing that had come up in her blood work is that, we knew she had E. coli in her urine. That is one thing that we were able to find. But they went through many screening with the anatomical imaging tests, and they couldn't come up with anything. That's all they knew. So they started treating. The infectious disease doctor, this is his note, Dr. Chaudhry, he felt like there was an occult source somewhere in the abdomen, but we just couldn't figure out where. So PET scan was ordered to fully evaluate. And this is her. I showed this lady's picture yesterday. It's one good thing about the newer equipment. This is I believe it's 165 kilo female. You're able to do a nice, you don't have any beam hardening. You don't have any streaking, no artifacts. She has a Foley catheter, which you can kind of see it in. That takes any activity out of the urine, out of the bladder. It allows, we do hydrate these patients. We do, typically these patients like this, they'll get a little extra, hang up 1,000 bags saline after the injection. We inject them on the floor so they're allowed to rest in their bed. We do instruct our nursing staff on radiation safety and what to do with these urine bags, because you do have to be mindful. If you start doing infection imaging on these very sick inpatients, this bag of urine will be very, very hot. We are injecting them with FDG, so we instruct them, and they have to. And actually, as a side point, this year in our facility, every single employee in the entire hospital is now required to get radiation safety program. Everyone, from the janitor to the nurse, every single person is required to get treatment or to get planning. This educational program. So now they know that they need to empty that urine bag, and they need to empty it frequently. If they need to measure it, they need to do it quickly, and they need to flush it and be careful and mindful, because these patients now the technologist has to go up to the room and survey, make sure there's no contamination and leaks and things like that. So I'm sorry. Back to a little side note. Back to this patient. This is a relatively clear scan. You do see in the around the kidney this activity, but that's not uncommon. You can see the urine coming out of the kidney show up quite often, but basically it was the only thing. It revealed a large staghorn calculus in the right renal edema, and that was the only real site. That the CTs didn't show it. The PET scan showed it, but upon further evaluation, that was the only thing. And this allowed her to stay in the hospital and get her treatment. She was supposed to leave in the afternoon of this exam. So this allowed her to stay and do more focal treatment. So the result, PET showed, the PET helped to show where she was growing E. coli, and it's helpful in the patient population that often cannot have diagnostic CTs, such as this patient. She was very ill. Her BUN and creatinine was too high to do diagnostic CT. And, the plain CTs of the chest, abdomen, and pelvis are very challenging when you don't have the contrast. So I'll show you one more example. This is a younger man, 56 years old, coming in with weight loss, feeling tired, abnormal labs, the fever again. This patient did have sarcoidosis. So that sarcoidosis is a common false positive for PET scanning. It's a big problem in the United States, often with the African American population. They have a larger prevalence of sarcoidosis. This patient also had normal CTs, chest, abdomen, and pelvis. So it was sent a consult for molecular imaging. So to review, no cancer history, fever, 30-pound weight loss on this patient. And he just kept working and trying to push through, trying to heal himself. He was tired, abnormal labs, fever, and sarcoidosis. Now this was a harder one with the sarcoidosis, because the sarcoidosis on PET, like I said, is false positive. But we did not want to do indium-111 on this patient. We didn't want to end up SPECT CT in the whole body. We didn't want to do that kind of imaging. So diffuse liver involvement of the sarcoidosis, these patients get complex quickly. Sarcoidosis typically doesn't doesn't cause the weight loss, things like that. Patients live quite a long time on the sarcoidosis. So as you can see, this patient, the weight loss, 30 pounds in 8 weeks. That's pretty quick. For mid-50 or late 50s-year-old man, he did have some anemia. You can see his kind of basic is fever. So the plan was to do the PET scan. So as you look at this patient, it's easy to kind of glance through it, but you look at the spine, and it is really hot and patchy. It's not like a lot of times you get the marrow activation and you can have a fairly hot spine for no real fair reason, especially in an anemia patient. The body's trying to heal itself, it's trying to activate it. But you can see there's virtually no uptake here. There's no uptake here. There's very little in the spinous processes. But very patchy, very hot. These SUVs were in the 20s on this. So that led to physicians were thinking about sarcoid most of the time. It's very easy in these patients for physicians or just human nature to kind of get focused on one disease state and not have a global idea of what's going on. But the PET-CT had to move him forward. So this patient found out that he had diffuse T-cell lymphoma and completely normal CT scans. So I found this patient really interesting. One of my technologists brought this patient to me and worked it up as a case study to add to this type of talk. And that just moved the patient out of they stopped worrying about the sarcoidosis and started worrying about his cancer. And just as on an interesting note, when we start going back and looking at all of our infection PET scanning, we're finding cancer a little less than 10% of the time. Cancer comes in fever. Cancer can weight loss, malaise, all of these things. We find lymphomas and other uncommon things. Even colon cancer can cause these things. So this supports our mission statement that we are committed to the care and improvement of human life. And then we feel very strongly that molecular imaging, the functional imaging, is a useful tool. This basically, all of these things were deemed false positives at one time in the early days of PET scanning. Now these false positives are now being utilized as we understand the glucose metabolism and the processes and the disease states of the body. These disease states are important, and you can use basically an old false positive now today. That's what we're using it for. So I just wanted to show you the patient care side. I particularly think this is interesting. In the state, I'll show you a little bit of reimbursement, and I know that's not so much an issue here, but we don't get paid anything for these exams. We basically do these for free, and I would like to share with you why. And for the chief techs in the room and things like that, we do these for infection or cancer. Infection is not currently reimbursed in the hospital setting. It was a big struggle for me to, our PET scanner is very busy. If I'm adding a patient, I typically have to have an explanation of why. Whether we're doing, cardiac PET is reimbursed, oncology is reimbursed, it's all understood. But when I go to my, hospital leaders, I have to explain why. So I would argue that PET-CT is better, and this is the argument I used, to make a comparison between indium-111 and FDG. So, I'm never really worrying about money, but I do worry about resources, and I want my departments to run efficiently. So just to show you in the United States, and from what I understand, this is similar in other places. If you're looking at an indium white blood cell, well, that's not really paid either, because, I know reimbursement's not the issue, but it costs my hospital $2,075 just to get, and I don't have the conversion to the dinar, but it costs basically, almost 20 times more to do an indium-111 scan. And we don't get results till day 2 to 4. So that patient is still untreated for 2 to 4 days as we allow delays and things like that. And it's a lot of my tech time. My technologists are busy, and this is 5 to 8 hours of moving patients around and imaging and them doing SPECT CTs and things like that. Well, as the FDG, I get results on day 1, and it's 2 hours of my technologist's time. So not only am I being more efficient, I'm saving money, and this is 20% accurate at best, indium-111 in cold infections. Well, this isn't a whole lot better, but it's still about 30% accurate. And I just strongly feel that it's just a better test. I save my facility money, and And that's really not so much what I care about, but I get results the same day, and it's more accurate. That's what I really worry about. So in words, in the U.S., will have to do a lot more financial talking, but it costs my medical center less money. It gets results the same day. That's really what I care about. Saving a day or four in the United States, we always worry about DRG, and that's how long patients are in facilities, and we have to report this to our government. So the primary impulse of imaging, and to be absolutely clear, we only make a suggestion of a site of infection or a cause of infection in 1 in 4 patients. So I don't want to say that this is, a perfect imaging test. 75% of the time we don't help at all. But that 25% of the time that we do, we're allowed to direct basically a biopsy. We're able to completely change patient management, which I think is pretty amazing. Because if you look at how many nuclear cardiology scans, how often we really change something, it isn't that often. It's not as high as this even. And I do think that we have somewhat of a selection bias, which brings down this number, but it's still 1 out of 4. And what I mean by selection bias is a lot of times these patients will have some sort of abnormal anatomical imaging, and that is really where PET-CT does a great job. If the anatomical imaging says there's something there and you use PET to figure out what that something is, PET excels. So that's what I mean by selection bias. So in conclusion for this discussion, FDG infection imaging is cost effective and a viable resource to evaluate these challenging patients. I do think we've tried 2 separate times in 2003 and 2008 to get the government of the United States to allow these exams, and have failed both times. And the main problem is we don't have enough data, and we don't know which patients to pick. But I still think that we're showing such a change in management that this is important. And as I said, more studies are needed to help determine which patients can benefit from PET imaging. And thank you.